We've got Sharon Neill. She's currently Vice Chair of the Society, and she's also a lecturer in nursing at Ulster University. And we've got Jo Swan, who's a trustee, and she's a senior lecturer in tissue viability at Birmingham City University. And the pair of them are going to be talking about optimising healing through effective debridement. So I'll hand over to you two now. Thank you very much.
Good morning, everybody. It's great to have you all here. As Sarah has introduced me, I am one of the trustees in the Society of Tissue Viability, have been since 2020 or 2019. And I'm here with my lovely colleague, Jo Swan, and we're here to tell you a little bit about a project that we undertook as part of the society, and obviously then how that can be applied to your practice here this morning. So hopefully you'll enjoy this, and we look forward to your questions at the end of the session. So this presentation is about optimising healing through effective debridement. And that's myself and Jo, and Sarah has already done introductions, so we're going to just skip past that for this morning. So what this presentation is all about is a project where we joined up with the nurses specialising in wound, ostomy and continence Canada and ourselves in the Society of Tissue Viability, and decided that there was a gap in the evidence to support clinicians who are out there undertaking debridement for wounds. So who was in the team? On behalf of the Society of Tissue Viability, we were represented by myself, Jo, Ina, who's one of our podiatry colleagues within the Society, and Claire Greenwood. And we joined up with, some of you may recognise some of these names if you're up to date on reading some of the tissue viability literature, but we paired up with Kim LeBlanc, Mary Hill, Erin Ranjanesi, Nancy Parlow and Kathy Harley, who represented the Canadian cohort in this project. The highlights from the work that we've done were that wound debridement, when carried out by a trained and competent healthcare professional, can improve wound healing and patient outcomes. And hopefully that's something that you'll see in your own practice day to day when you're undertaking debridement. Best practice recommendations for wound debridement were originally created for nurses in Canada. So before this project started, the NSWOC team had already created a portfolio of statements that they related to their practice in Canada. But what they did was they felt that the work that they had done was internationally relevant, and contacted us at the Society and asked us to work with them in getting agreement on those statements and sharing the information wider on an international platform. We used a research method called the Delphi method, which, for want of a simple explanation, is really voting to get agreement from everybody in the room that these statements would be carried forward and would be internationally relevant. So we went on to develop a series of consensus statements that were relevant for all healthcare professionals who perform wound debridement. And whenever we talk in a little bit more detail, and Jo will expand on that and all the different forms of debridement, you'll see how it is relevant whether you're a nurse, whether you're a specialist nurse, whether you're a surgeon, podiatrist, or another professional who undertakes debridement. The aim of the project, like I said, was to develop the best practice recommendations for wound debridement with an international perspective by creating a consensus document that was based on evidence-based practice for healthcare professionals. And that's something we feel very strongly about here within the Society, is getting best practice out there and available for you as clinicians on the ground. A little bit more about the Delphi method. We were able to conduct the Delphi session online, which was fantastic. Obviously, we were working alongside our Canadian colleagues. We had oceans between us. We had time differences between us, but we were able to coordinate it and do the session online, and it worked really, really well for us. In order for a statement to be accepted by the group and carried through to our best practice statement document, we needed to get 80% minimum agreement within the group. So if there was a statement of which there was none, that didn't reach that 80% threshold, it wasn't to be included in the document. But fortunately, we agreed all 15 statements, and they were agreed at 80%, and quite a lot of them were agreed at 100%. Then, when we had reached those 15 consensus statements, we didn't just accept our version and that we were right as a small group of individuals and clinicians. We then sent our initial findings out to a group of stakeholders for review. And that included podiatrists, nurses, academics, teaching on a global scale as well. And all in all, there were 14 external experts approached to do that secondary peer review process. I am just going to then take you through very quickly the final 15 consensus statements in the hope that you will find this useful, that you'll be able to think about these and how these impact you personally and professionally in your day-to-day patient care delivery. But there may also be some of you in the room here today who are working at a policy level, at a strategic level, where these 15 consensus guidelines and statements might help you to ensure that you are supporting and keeping your clinicians who are out there undertaking wound debridement safe. The first statement that we agreed was that all forms of tissue debridement carry high risk when initiated inappropriately. However, surgical and sharp conservative debridement have considerable risk even when performed by healthcare clinicians with knowledge, skill, judgment, and demonstrated competency. So when most people think about debridement and we talk about debridement, they automatically go to the extreme of surgical and sharp debridement. But remember, and there are lots of other forms of debridement that you will be undertaking in everyday practice. But we do see that surgical and conservative sharp debridement to be a higher risk procedure. So it's important with any form of debridement that prior to the initiation, the healthcare clinician must conduct a comprehensive, holistic patient assessment. And that's really important and really key that is undertaken and that is well and clearly documented in your patient records before any form of tissue debridement. Clinicians, before initiation of any form of debridement, should conduct and document a comprehensive wound and peri-wound skin assessment. So really important as well. Prior to the initiation of any form of debridement, the healthcare clinician must assess the patient's setting to ensure the environment is safe to perform the debridement modality. So again, you'd be thinking perhaps for surgical and conservative sharp debridement, you may need to undertake that where available in a slightly more clinical setting. And other forms of debridement are obviously safe to do in community and home settings as well. Statement 5, prior to the initiation of any method of debridement, it is essential to establish realistic treatment objectives that align with the patient's goals. So that's really important consideration. What do you expect this debridement to do? And making sure that you have considered that before you undertake debridement, but also that your patient has realistic expectations about what the outcome of debridement will do, and make sure that those align. And if they don't, conversations and further shared decision making needs to happen. Statement 6. Valid and informed consent must be obtained and documented prior to performing all forms of debridement. And that's really, really important. Not every form of debridement will require a signed consent form as such from your patient. Some will, but ultimately some record of how that consent process took place and how that consent was received is really important part of your clinical documentation. Statement 7. Healthcare clinicians are responsible and accountable to know and must work within their scope of practice. And that's really important. We have a large audience here today. I think I see 110 people on the screen. So I think within that group, there will be lots of varieties of scope of practice within that. Some of you will be undertaking debridement methods supported by dressings and maybe things like larvae therapy, and some of you will be undertaking that conservative and surgical sharp debridement. So it's important for you to acknowledge and recognise your own scope of practice and your own limitations. Statement 8, healthcare clinicians must have education specific to wound care prior to initiating or performing any form of debridement. And obviously the level of wound care and the level of education should be aligned with the risks associated with the form of debridement being undertaken. And some forms of debridement will have very specific education requirements. Statement 9, healthcare clinicians must have education and training specific to their various forms of debridement prior to considering or initiating any form of debridement. That's about us self-regulating and being aware of our own capabilities. Healthcare clinicians performing high-risk forms of debridement, for example, that's surgical or conservative sharp wound debridement, must have education and training, including a period of preceptorship, prior to considering or initiating performing high-risk debridement. Healthcare clinicians must maintain their competency through continuous professional development, and as healthcare professionals, our regulatory bodies are regularly reminding us and holding us to account in relation to our continuing professional development. But if wound debridement is an activity that you're carrying out on a regular basis, it's important that you acknowledge that some of that professional development that you're undertaking as part of, revalidation processes or whatever your governing body requires you to do, that you consider some further development in that area on a regular basis to make sure that you stay up to date. As a healthcare clinician undertaking debridement, you must understand the mechanisms of action and the appropriate use of any wound care products or therapies that you're including in your patient's treatment plan. If you initiate it, there's an expectation that you have that underlying knowledge and understanding. Healthcare clinicians must consider and reevaluate the costs associated with various forms of debridement. That's not only the cost of the treatment itself, whether it be the dressing or the debridement kit that you're having to single use that you're having to use, but also the time and implications on other resources like yours. So you have to understand that process and decide as part of your decision-making process about cost effectiveness as well. Employers and organisations should have policies and procedures in place to support healthcare clinicians in the provision of evidence-based wound care. And I think that's really important. And that is perhaps where we suspect that some of the gaps may lie. But if you're the clinician out there who is undertaking debridement and you feel that there is a gap in your local policy within your organisation, then you need to highlight that and you need to maybe direct them to our documentation here to help inform that process going forward to keep you safe as clinicians undertaking your day-to-day work. And finally, as with everything in the world of research, we've decided that more research is required. And that's important that we continually review this document ourselves and the statements within it to make sure that they're still appropriate and relevant to practice. And as new information comes to the fore, that we'll be able to amend and inform best practices and give you the best up-to-date information as clinicians out there delivering the care. So in summary, we do have a link and a QR code at the end of Joe's presentation. Joe's coming up next. That'll take you directly to that document. So in summary, what does the document tell you if you go to find it and read it? The statements presented are of a collaboration between ourselves and our Canadian colleagues, the national or the nurses specialised in wound and ostomy and continence care. These statements are aimed to provide guidance in the standardisation of care within the field of wound debridement. And The bit that you're going to hear from now from Jo is the nice clinical bit and the application to practice. Debridement stands as a cornerstone in the realm of wound management. It's pivotal in advancing healing and curbing infection, and it's appropriate that we use it when required, but we're also safe and competent in how we approach that. So I am now going to hand over to Jo. Jo, do you want me to stop sharing and then you can take control? Is that... Oh, you're on mute still?
Yeah, it's just downloading. I can stop, don't, oh yeah, okay. Yeah, stop sharing and I'll
You can take over.
I can take over, yeah.
Thanks for your patience with this, everybody.
Just downloading. So, sure. The first thing just to think about is the confusion there might be between what is debridement and what is cleansing. And essentially, cleansing is about facilitation of removal of devitalized tissue, whereas debridement is the actual removal. Can everybody see my screen now? Is it
Sharon,
sharing?
sorry to interrupt you. We can see your screen, but you're not on full screen, so we can see all your notes.
Okay.
So
Bear with. No. It's really slow. There we go, slideshow. Has that worked?
No.
It's because I've got 3 screens. Just give me a sec.
Yeah, no, I get it. It's
Let me go to, let me get rid of that one. Sorry, everybody.
don't worry, it's part of life.
You might just have to do the QR code at the end because I'll go off mine. I've got my, I'll just load mine. It might work better. Let me get rid of all of that. Sorry, everybody. That worked.
I'm not seeing anything, but it sometimes just take a couple of minutes to come through. So
Definitely sharing my end, but I think it's going to come up on my 3rd screen again.
Look, I'm happy to share. I'll be your glamorous assistant, Jo. Just tell me when to change
Sorry.
slides. No problem.
Should have done a dummy run.
I can share for you, but Sharon, you might be a better opportunity because you'll know when Jo needs to move on. It's up to you.
Okay, so yeah, debridement versus cleansing. So while we might do a bit of mechanical debridement with cleansing, that's not the aim of that. It's mainly a facilitation process, whereas debridement is the actual removal of viable and non-viable tissue. Next one, please, Sharon. So why do we need to debride? Well, we need to promote healing, and we know that devitalized tissue acts as a physical barrier. You'll just need to keep clicking, Sharon. It's a focus for we've got devitalized tissue as a focus for infection. We want to reduce bioburden. We want to manage biofilm. We want to stimulate the wound edges because we want those epithelial cells to skate across the wound, manage some malodor. And there's a quality of life issue here whereby if we're managing that wound bed, we're going to help reduce odor and hopefully reduce exudate as we push that wound into a healing trajectory. Next one, please, Sharon. But let's be clear, it's not just about reducing infection. If we're stimulating the wound bed and we're improving that wound bed through doing some good cleansing and debridement, then we're going to help with other factors related to the wound healing process. So there's uncontrolled matrix metalloproteinases. These MMPs are vital for normal wound healing, but in those non-healing wounds, they can become uncontrolled. They're not switched off by their tissue inhibitors, and they can cause that wound senescence. So we know that MMPs are raised in non-healing wounds, and they will cause this continuous breakdown of the extracellular matrix. We get reduced activation and modification of cell signaling molecules and growth factors, which contributes to that senescence within the wound bed, reduced growth of new blood vessels, and reduced reepithelialization. And they are inflammatory cells in themselves, so they just continually push this wound into an inflammatory cycle. Next one, please, Sharon. So what sort of tissues are we going to be looking at when we're talking about debridement? Necrotic tissue is probably the obvious one, usually hard, dry, leathery tissue, but we do see as it starts to soften, it gets that more floppy, gelatinous sort of presentation. But it occurs due to those uncontrolled factors in the external environment of the cell, infection, toxins, trauma, and a poor blood supply. So we've got ischemia and cell hypoxia. Necrotic tissue acts as a physical barrier to healing. It's totally unreceptive to growth factors, so there's nothing happening around that tissue, and it will support that bacterial growth and increase bioburden. Next one, Sharon. And then we've got slough. We see it all the time, don't we? And it can present as really thin, friable yellow tissue. It can be really thick, tenacious, yellow, almost brown tissue. And it's a normal byproduct of the inflammatory process, and it contains fibrin, white blood cells, living dead cells. It's very proteinaceous material, and there will be microorganisms. It's a great medium for bacteria to grow in. So we will get that wound that is stuck, usually in that inflammatory phase of healing. So we've got increased exudate, and with that we get nutritional loss and dehydration, which are problematic, prolonging that inflammatory response. Bacteria love to sit in that slough and proliferate. We'll have increased odour. It impedes the assessment of wound depth. That is particularly tricky when we've got perhaps pressure ulcers we're looking at, and it will delay wound healing. So I'm just going to focus on those first two statements that Sharon's already gone through. So let's have a look at the methods of debridement then. So we've got lots of different methods of debridement, and it can be really tricky deciding what is going to be the best and most appropriate method of debridement. Just click through them, Sharon, thank you. The thing is, there's no evidence to suggest one method is better than another, and you're likely to be using more than one method at a time. So you may start with some mechanical, but you're going to then continue with autolytic debridement, for example. But assessment of the patient is absolutely key. We need to look at the patient, the environment, in order to be able to choose that appropriate method. Keep clicking, Sharon. So we need the right method at the right time for the right wound and the right patient. So what do we need to consider when we've got that patient in front of us? Well, we need acceptability for the patient. What is best for them? How do they feel? They may not want you to go anywhere near them with a scalpel, for example, or indeed maybe lava therapy. We've got to consider their pain. Is that wound pain? Is it general pain? Are we managing it well? Can the patient position themselves and remain in that position? Because that's really going to have, or is there an ability for us to put them in a position that's going to have an implication, particularly around sharp debridement? What are their underlying conditions? Are we managing those as best we can? Because healing is not going to happen no matter what we do if we're not managing those underlying risk factors for delayed wound healing. Age can be an issue in terms of the very young. Is it appropriate to use some types of debridement on the very young? There's a fear and anxiety perhaps. And equally, as we get older, how cognizant is somebody perhaps around what we're doing and what we want to do with them. We need to consider medications, particularly anticoagulants, because we don't want to encourage any bleeding. In most cases. What is capacity? What is their capacity? Can they understand what we're going to do? Are they going to be able to, I hate the word comply, but it's important in terms of positioning the patient perhaps when we're doing certain types of debridement. And as Sharon's already mentioned, consent. And sometimes we do have to make some best interest decisions for patients in terms of the care that we give, but consent is important. So what are the considerations when we're choosing a debridement method in terms of the wound itself? Well, what is it? What have we got in front of us? Do we know? Do we need a vascular assessment? Do we need to refer to other services like dermatology to get that diagnosis? How big is the wound and where is it? That could have an effect on our choice in terms of we don't want to be using ointment type forms of debridement if the patient is weight bearing on that area, for example, because all it's going to do is squish up the sides and not get to where you want it. What type and amount of devitalized tissue have we got? Is there infection present, and do we need to get that managed first or alongside what we're doing? And we need to know what underlying structures we've got in the area, because that might preclude us using any form of sharp debridement. And you can see in this picture, we've got some fairly prominent tendons visible. So we've got to think about, is the wound healable? What's realistic? Is this just a quality of life decision, and in that we want to try and reduce odour and manage exudate? Are we looking at biofilm disruption? And what do we need to remove? What types of tissue have we got present? And what is going to be the best method for the job? Other considerations is, where are we doing this debridement? What's our setting and what's the environment like? Are we in a patient's home? Have we got a lot of clutter around? Are there pets around? I'm sure most of you have had experiences of cat hairs in wounds. I've had a couple of patients, I don't know why, just recently, where having a pet licking the wound is what they quite like, because it's going to clean the wound. Yeah, quite interesting, but it's definitely a thing. What's the practitioner's knowledge, skill and competence? What is your scope of practice? What available resources have you got? Thinking about cost and what's most cost effective. We've got to think about disposal of consumables and maybe sharps. And what is the evidence sitting under the type of debridement or the product that we're going to use? We know evidence is scarce, but we can't ignore that. And equally, just because we haven't got evidence available doesn't mean that that particular thing that we want to use doesn't work, but we need to be mindful of it. So, debridement methods commonly available in practice. We haven't got time to go through everything, so I've picked a couple that I thought would be most appropriate. Mechanical debridement. We've got a number of different things available to us. Some aren't really very useful in certain environments. So the pulsatile lavage, for example, there are infection control issues around that. And wound irrigation, you've got to have the right pressure in order for that to work. But we do have access to monofilament pads, specialist sponges, and those specialised cleansing cloths. It can be really quick and cost effective, but it can be painful and it can be time consuming. And I've certainly found that sometimes a monofilament pad is the most appropriate. Other times a specialist sponge or a cleansing cloth. It sometimes depends on the type of devitalized tissue you've got in front of you, but it can take a time to get rid of it, and you need to prepare the patient for that. The most common form of debridement is going to be autolytic debridement, and this is naturally occurring. We have our own proteolytic enzymes that work to liquefy and remove non-viable tissues, and we have our phagocytic cells, such as our macrophages and our neutrophils, that will help also remove non-viable tissue from the wound. However, we know that we need to facilitate this in these non-healing wounds because it's not happening in a timely way. So we've got multiple different dressing products. Some will donate moisture, some are going to absorb excess moisture, and we want to get that balance right. So we've got our alginates, hydrofibers, hydrogels, hydrocolloids, honey, alginogels. There's loads out there. And we just need to be mindful of the location of the body if we're using any kind of gel, for example, thinking about pain. But these options will support and speed up our own natural processes for wound debridement. And then we've got our lovely maggots, the ones that are left usually as a last resort, but they do so many things. The type of maggots that we use, they've got a really high appetite, and they will dissolve that devitalized tissues with proteolytic enzymes. They'll loosen that tissue with their mandibles, and they will promote cellular activity. They dissolve microorganisms on the wound surface, and they secrete an antimicrobial that will also help to reduce that bioburden. But they consume those microbes in their gut and kill them off, so that they're constantly reducing that bioburden. So there are some advantages. They don't harm healthy tissue. They're quite quick in terms of their debridement. You can move on one, Sharon, thanks. We've got the antimicrobial action, and they can be really cost effective. And there's a number of papers out there that suggest that, even though the initial cost appears high, which will put some people off. We do have a yuck factor, both as clinicians and as patients, that sometimes we need to deal with. We can't use them on very wet wounds because they will just drown. And we've got to, again, be careful on those weight-bearing areas because we don't want to squish them. We've got to be careful with bleeding wounds because they can encourage some bleeding, and those blind cavities or sinuses. Now, we're tending to use bags of larvae now rather than free-range larvae when this was a real particular issue. But still, we could lose a bag down a blind cavity. We've got to be careful there. And then the very dry wounds, because if they're too dry, they can't actually get their mandibles into the tissue to start liquefying it. Surgical debridement, it's a more invasive approach. It tends to be on those bigger wounds, perhaps really painful wounds that the patient isn't going to manage any kind of debridement at the bedside. It will take viable and non-viable tissue. There will be bleeding, and there's likely to be pain post-surgery. It's appropriate for those bigger wounds and those painful wounds. But we've got to think it is a costly option, and it's often going to require a form of general anaesthetic, so it isn't without its risks. But there are certainly some patients that it is absolutely vital that we go down this surgical route. However, we do have the option of sharp debridement and conservative sharp debridement, so it can be very rapid and cost effective. We're going to get rid of that tissue fairly quickly, whether that be with a scalpel, with scissors, or a curette. It does require a skilled and competent practitioner and the underlying knowledge of what you're doing, why you're doing it, and a good understanding of the AMP of the areas that you are debriding. We need a good environment that's well lit. We need to be able to position ourselves and the patients properly. We need to be mindful around the patient's sort of anxiety state, because we don't want them moving around while we've got potentially a sharp object in our hand. And we've got to think about blood supply and that potential for bleeding. And again, consent and informed consent is important here, though I have done CSD as a best interest decision where there's been a clear issue with the potential for sepsis. But conservative sharp debridement does not extend to viable and bleeding tissue. You may see some pinpoint bleeding when you're using conservative sharp debridement, but on the whole, that is not what we're aiming to do. So following good assessment, what are we going to use? We've got different instruments we could choose. So if we are deciding that CSD is absolutely the way to go, what are we going to use, how are we going to do it, and why? And we need a sound understanding of what we're doing, why we're doing it, and how we're doing it. So we've got to think about sharp debridement safety. What are the things to consider? We've got to think about where the wound is, what types of tissue are present, and what underlying structures may be there that are going to come, we're going to come potentially close to using a sharp instrument. What type of wound have we got? Is it healable? Is this an appropriate method? You can't ignore pain. In theory, we're removing devitalized tissue, but patient will still feel pulling and tugging as you lift that devitalized tissue. We've got to think, can the patient hold that position? Is there that anxiety? Is there an issue around their cognitive state? Because we don't want them moving while we're performing this CSD. Those comorbidities and medication we've got to consider. What's the environment like? Have we got a good, well-lit environment? Is it clean? Have we got space? Can we position ourselves to perform the procedure safely? Again, that's skill and knowledge. What equipment have we got available should things go wrong? And have we got people around us should there be any kind of adverse event? And we've got to be able to dispose of the clinical waste and sharps appropriately. So it's a whistle-stop tour, but in summary, wound debridement is a vital component of managing hard to heal wounds. We can't ignore that, and we should be doing it at every single opportunity where that's appropriate from our assessment. We've got to choose the right method at the right time for the right patient and the right wound, and we've got to make sure we've got our good underpinning knowledge of the methods that we're using, their advantages and disadvantages. And we've got to have the patient at the centre of our decision making. What factors must we consider? And we've got to make sure that it's good positioning. We've got to have a look at their pain and make sure that's controlled. We have to have our own aims and the aims of our patient in mind. And we've got to make sure that we consider consent. Thank you for listening.
Thanks, folks. That was really, really brilliant. Lots to think about there. We haven't got an awful lot of questions in the chat at the moment. Do you want that people to scan that QR code, do you, Jo, for the document? Yeah, for the article? Yeah, that's great. So yes, if you want to do that, but also the link has gone into the chat as well. So if once this has stopped sharing, it is in the chat for you to refer to. Really interesting around sort of scope of practice, and there was a question there from a nursing associate about whether she would be able to sharp bride, maybe given a course. What I've asked Dawn to do is to put into the chat a couple of documents. There's a really good one around community and sort of practice nursing, sort of capability competence. It's a new document that came out by NHS England, I think the earlier this year, as well as the very snappy title of Wound Care Workforce Framework, which we know and love, obviously. But it, you know, certainly with the community and the practice nursing document, it does exclude nursing associates from sharp debridement, and that I don't know what your thoughts on that are. You know, this is about protecting the clinician as well as the patient, and it's also about the level of education and understanding and where that professional accountability sits. I don't know if you want to comment on that at all.
Well, I have nurse associates going through my debridement module through the university. But I think the key thing is the support around them where that sharp debridement is happening, because it tends to be specialised clinics where there's a lot of additional education and additional support, and there's a wider governance framework in those areas. So I do think there's it doesn't preclude, from my point of view, with the right training and underlying knowledge, it doesn't preclude nurse associates, but I think it really is about the environment, the support, and the governance to protect them and obviously the patients. So under normal circumstances, not, but I think there are definitely areas, and it tends to be those specialised clinics that are allowing nurse associates to perform CSD.
I'll maybe just add to that, Jo, I suppose, yeah, it really comes down to each individual. It'll be what's, you know, what you're covered for in terms of your job specification, your job description, what your manager's supporting you to do. You know, on the flip side of this, I managed a tissue viability team with band 6 and band 7 clinicians who were not conservatively sharp debridement because they did not have access to the education and training to support their development in that area. Yeah. So it's not an automatic right when you get tissue viability in your title to be able to undertake this. It's about looking at benchmarking where you're at and where you need to be able to sort of, you know, and again, I keep referring you back to the consensus document, have a read through those statements. You know, where do you sit against that, those best practice recommendations? And like Jo said, you know, it's not specific to any job title. It's about the education, the preceptorship, the governance around that will dictate whether it's appropriate for you to do that as a clinician.
Thank you. Could I just ask you just to stop sharing now, please?
Yeah, sure.
That's great. The link is in the chat. I absolutely agree. I think it is around that level of supervision, you know, and that support, isn't it? You know, we know that so many people work in isolation and haven't got somebody to hand if something went wrong. There was an, you know, adverse reaction or something to the debridement. So, but yes, a lot to think about there. Let's have a look and see if anything's come in. I think. You know, you talk about mechanical No, there's nothing else at the moment. Mechanical debridement, which I think a lot of the generalist nurses here today will be, you know, undertaking a lot of that with the modalities that are available to us. But it's not necessarily just so straightforward. I think that there still needs to be a knowledge base behind that device that they're using, and maybe, you know, that's not always. I know that a lot of areas, particularly talking about the community, you know, there are barriers or blocks for industry coming in to support people, but it's really important, isn't it? You know, it's whether it's a dressing or it's a mechanical debridement device, we need that support for people to show us how to use these things properly. So I would say we should be encouraging that, shouldn't we?
Absolutely, definitely. It's vital. And we know that there is a minimal time for people, you know, clinicians have with people, with patients. And actually, if there's one thing you can do, is do some really good cleansing and some mechanical debridement, you're definitely going to, you know, improve the situation for that patient if you can factor that into your care.
Yeah, and I think, Joe, you touched on it during your presentation as well. There are things out there, you know, sometimes we're quick to reach for the scalpel or for the scissors, but because it's deemed to be more cost effective than, for example, you know, the larvae treatment, which I do think becomes a last resort for clinicians, when actually we could be reducing our healing times for patients by getting that debridement done early and considering, you know, yes, the upfront cost with that, but the long-term gains for those patients and for the resources of your time as well. That's something that we need to consider too.
Yeah, thank you.